Welcome to InnerSight, Health Optimization with Rudy and Shaun.
Right, here we go. We've got a guest in today. So our InnerSight podcast, looking at longevity. Me and Shaun been on the journey to try and get our listeners to a good 80, and we brought some brains in today. Hofmeyr Viljoen, Dr. Hofmeyr Viljoen is a good friend of ours, studied with us, and is now a radiologist in town. And he was trained as a medical doctor in Bloemfontein, then became a radiologist at Stellenbosch University, has worked all over the world, and is still reporting for people all over the world. So worked in the UK, worked in Canada, and is currently a senior partner in SCP Radiology in our northern suburbs in Cape Town. Hofmeyr runs quite a big show. They've got 10 biggish centers where they run x-rays, ultrasounds, CT scans, MRI scans, so the whole modality of radiology. And we've got him here because we do use their services for quite a few of our patients that need screening tests. So we need to learn from him, and we want to pass on the knowledge of what can be done and what can be picked up, and are there any new things? So, Shaun, maybe you can take us to what we do currently, and then we can take off from there.
Yeah, thanks, Rudy. Yeah, thanks for having me on.
Yeah, excellent. Thanks for joining us. So, yes, we do use a couple of tests, and mostly screening tests for our clients. And often we get questions from them regarding what does it entail, how does it work, how much radiation you get from the test, and things like that. And I think it would be nice just to go through a couple of basic tests today, just in general terms, so that people can understand what it's about. And then we can maybe talk a little bit in more depth about certain tests that we use in the practice. So I think let's just start off with what tests are available, and more or less what do they do and how do they work.
Well, in radiology, you basically use three types of energy: sound energy for ultrasounds, electromagnetic energy in CT and X-rays, and then magnets, strong magnetic fields in MRI. And the radiation dose is really only with X-rays and CT. So that's high energy photons get shot through the body and absorbed by a detector, and that's really the only risky test that we do. In parentheses, risky. Everything is a risk. You just have to look at the dosage. With ultrasound and MRI, really very safe, except for maybe perhaps the strength of the magnetic field if somebody accidentally brings something metal into the enclosure. But ultrasound and MRI are very safe. So if you talk about radiation dose, most people won't have a reference value, and the units we use to measure radiation is called the sievert, and the levels that we deal with is millisievert. And to just give you a reference, the amount of radiation that you would get just living for 1 year on this planet is about 2.4 millisievert, and which is about the same as you'll get from a coronary calcium score. If you get an X-ray, it might be 0.2 millisievert, mammogram at 0.4, and obviously CAT scans and angiograms have significantly higher doses.
So that's actually quite little. It's a lot less than people think, or even I thought up to now.
Yeah. People often CT scan is 40 X-rays or 80 X-rays, and that sounds a lot, but an X-ray is actually a minuscule dose. And the risk is really extremely low. But you always, with X-ray, we have the principle of, it's called ALARA, as low as reasonably allowable. So we're always trying to keep the dosage as low as possible. And we wouldn't image somebody with ionizing radiation if we don't think there's going to be a benefit from it. And that's very important with the screening. We won't just send anybody off the street and says, let's say I'm concerned I might have a pancreas cancer, can you do a CT scan of me? There's no evidence that the risk after the benefit outweighs the risk, and we wouldn't do that. If he says he wants to get scanned for an MRI scanner, we might tell him that the financial risk doesn't outweigh the benefit. But if he wants to do that, we'll discuss that. But at least there's no, medical risk.
Yeah, that's it's actually one of the things that we always think about. Like, there's a lot of risk, but there's actually not that much risk. So that's a great learning point. And X-ray, if you think about it, DEXA, that is also a low dose. Just to bring the listeners in, so a DEXA scan is a scan that we sometimes order to try and gauge the body composition of some of our what's the word I'm looking for? Overfed clients.
Overfed.
Yeah. So we're looking to prove how much muscle mass versus visceral fat someone has got, because they don't always believe us if we see the blood work, but there's also not a lot of risk in that.
DEXA scan is an extremely low dose. I think it's about 0.03 millisieverts, so that's about a tenth of a chest X-ray. So I think because you tend to lie down on the DEXA scanner for 15 minutes, you're lying on your side and your back, and people think, I've got this beam pencil, it's a pencil thin beam going up and down for 15 minutes. I'm getting lots of dose, but it's an extremely low dose.
Yeah, so obviously we would like to use that also to guide us regarding lean body mass. And not just the visceral fat. So, and effectively, we could do a test like that yearly or every second year to see that they're not losing muscle mass or lean body mass.
Yeah, definitely. DEXA radiation is really no issue there.
And you can also use the DEXA then to look at the bones.
Yeah. So the primary use is to look at the bone density to stratify the risk and say whether you're on par. If you younger patients, we compare you to your age group, 45 to 50 years, and we use a Z score. And for older patients, postmenopausal women or men older after the age of 60, we use a T score, which is just a general reference value to say whether you on par or osteopenic, which is 1 standard deviation below, or osteoporotic 2 standard deviations below. And
is that for their age group then?
For their group postmenopausal,
okay.
Which means that if you're osteoporotic, that you are at significantly increased risk of having a fracture or a major fracture, hip fracture, which carries a lot of morbidity and mortality.
Yeah, that's something we do order. So we've seen quite a few DEXA scans come through, which is nice.
Yeah, we've got a relative young practice. I mean, most of our clients are between 35 and 55, but as we grow, they're going to stay with us. So at some point, we're going to move into the realm of where we do screening for osteoporosis as well. Currently, we use it more for body composition than for osteoporotic type of screen. But yes, we will definitely move into that at some point.
I think all modern DEXA scanners can do the body composition, although it's not used often. We definitely appreciate some patients.
And then the thing we normally order the most is a CAC scan. That's coronary arterial calcium score. We get a value to tie in. Mostly it's the people that are on statins or ezetimibe for cholesterol, and we want to get a value. Can you maybe take us through? I mean, that is a CT scan.
Yeah.
So just for our listeners again, you would get to SCP, book in, and they'll take you to a CT scanner, which is like a donut that you lie in, and they take you through in and out. But it's quite quick.
Yeah, well, the nice thing about a calcium score is it's completely non-invasive. You don't need an IV. There's no injection, and with the discomfort and maybe the small risk that comes with that. And it's a quick exam. The exam itself, the scan, takes 10 seconds perhaps. The preamble and getting you set up and lying down and putting up ECG leads, because we gate the heart just to get it as still an image as possible. But it's completely painless and uneventful. And radiation dose is, I think, about 2 to 3 millisieverts. So that's about 1 year of just walking around, and the benefit that you get from that information, that certainly greatly outweighs raise the risks.
Yeah, so you grade the calcium that's in the artery walls to guide a score. You use an algorithm to get a score for us.
Yeah, so that score was set up, I think, in the 80s, called the Agatston score, and that there's a linear relationship between the amount of calcium and the cardiovascular risk. The more calcium you have, the more risk you have. And so a calcium score is a good way of risk stratifying, but also following up treatment to see whether you're going in the right direction. So that is also often a study that you'd repeat.
Yeah, we like the study for our asymptomatic patients, slightly, in the 55, slightly younger patients that we just want to guide in the treatment. We've got some resistance against taking a statin or one of the other cholesterol-lowering drugs to get a score done. But a 0 score doesn't mean that you don't have plaque formation.
Yeah.
It means that you don't have calcifications in the plaque.
Yeah, so I mean, seeing the plaque often is a wake-up call for the patient, and he realizes, okay, things have happened, and that's exactly what it means. Something has happened in the past, and the plaque is probably already stabilized, but it is calcified and it's harder. It's less likely to cause problems, but that just means there is other plaque that hasn't stabilized yet, and certainly if you have no plaque, if a patient has chest pain and no plaque, he might still be at great risk because the plaque just hasn't calcified yet and you could still narrow the lumen. So if a patient is symptomatic and he's got chest pain that could be cardiac, certainly you wouldn't stop at just a calcium score.
Absolutely. And I think the statistic says around about 10% of the CAC scans that's got a 0 score might have still have plaque formation, and about 15% of those, they might have severe occlusion actually without seeing it on a CAC scan. But still, it's an excellent screening test for us.
Yeah.
Yeah, and I think we picked that up going through the Canadian and also European and Australian guidelines. They do CAC scans much earlier than we do in South Africa. So I think most people at the age of 50 in those countries would have had one of those scores and would have had a benchmark. And I think so much of what we do is looking at the data. We don't want to catch you when you're actually symptomatic. We want to catch you 20 years before that, so we can have some type of a track record. And I think that's the main thing, is screening means, as you were saying now, if someone has chest pain, it's too late almost for us to be involved. We need you 20 years before chest pain or 30 years before chest pain. So
absolutely. And even with the CAC scores, I mean, you're going to read up and you'll see there's certain numbers they use to treat. So I think the latest that I saw was once you get a score of 200, then you should institute statin therapy. But if you think about the whole process of atherosclerosis, once there's calcifications, the disease has started. So to wait for a score of 200, so we'll advise our clients, listen, there's already some signs of calcification, even if the score's under 200, and then give them the option to start preventative treatment there. Well, matter of fact, it's not preventative then anymore. It's actually secondary prevention.
And so now if we add a little bit of risk to a CAC scan, so we've done a few of these as well. So then you get a CT angio, which is then a CT scan of your heart vessels. And with that it's again a CT scan, but now you've got a drip or an IV going in with contrast.
So the CT scan is the same machine, same staff, and the initial part is the same. We always do a calcium score to start off with, to plan, and if there's too much calcium and we have a cutoff value about 1,000, then we consider not going ahead because you might get too much artifact. But the difference is you also hooked up to an ECG, but the difference is, like you said, you would get an IV, in near your elbow, it's kind of an intravenous access. And during the scan, we would inject about 100 mils of intravenous iodine-based contrast, and that is to outline the vessels. Generally, before you get booked for a coronary CT, you'd also have to take some heart rate lowering medications, beta blockers, because ideally you want to have the heart rate as slow as possible, because we want to image the heart in the diastole, that part just between heartbeats where the heart is just waiting to beat, and is that it's motionless, so we don't get motion artifact.
Is there a number where you can't do it anymore with a
We
heart
prefer
rate?
having the heart rate below 60, and but the newer scanners, which we might get this year, heart rate, the dual source CTs, heart rate is no longer an issue. You could do a score, a scan up to a heart rate of 100, 120. But, the slower the heart rate, the better the quality. So generally, you would have to take a beta blocker. Even if your resting heart rate is 60 or 55, we get this white coat syndrome when you tend to see a doctor and you go lie down on this donut, you tend to, your heart, adrenaline pumps, your heart races. Yeah. So we prefer you to be beta blocked for about 3 days. There is an option if you're not beta blocked or the heart rate is still a bit high, we can give you some IV meds, beta blockers, metoprolol on the table. And but we want the heart rate below 60. And it has to be a regular heart rate. At least for the scanners that we have, if you have something like atrial fibrillation where the heart rate is extremely irregular, then the quality is often not good enough. And if you need an angio, you probably need a catheter, a normal catheter angio. But it's also a quick exam. We do a couple of training runs to make sure you can cooperate with the breathing and, to get your heart just a bit relaxed. But the whole in and out on the table, probably just 10, 15 minutes.
So slightly more risk to the procedure because of using contrast.
Yeah, and the big risk there is obviously an allergic reaction, which, happens at about 1 in 5,000 people, but it's, almost always mild reactions, just some skin rash and itching. And that's the biggest.
You only do it in centers where there are emergency rooms very close by. So your chances of having any major effects is actually also quite little.
We almost never get major reactions with healthy patients. The patients that tend to get reactions are generally patients with chronic illness and kidney disease and COPD, emphysema. And the healthy patients generally do well. And often patients come to us and say, well, they're allergic to iodine. They had an elastoplast with iodine on it with a reaction, and that's not relevant. That's not the same iodine. Actually, you're not allergic to the iodine in the contrast. It's more the secondary particles, the preservatives, that cause the reaction. And also the allergy to shellfish and seafood also has absolutely no relevance.
And if you've got someone that had a allergic reaction before, but you need to do a retest for some reason,
well, if it was a mild reaction, maybe just some skin reaction and hives and itching, we would prep them, and they would get some prednisone for a day or two, antihistamines, and then it's safe to go ahead. If they've had an anaphylactic reaction, so where the blood pressure drops and they become seriously ill and they need adrenaline or fluid and resuscitation, we tend to say, probably not. You need something else. But unfortunately, then the same contrast we use for CT is this same contrast that they use for catheter angiography. So you're running out of options then.
Yeah. So I think while we're talking about CTs, maybe you were talking about patients with previous lung disease, and that's another CT that we sometimes request is a low dose CT to screen for lung problems, mainly for lung cancer. Then, so we've done a podcast on the cancer side, so you can maybe go and listen to that piece. But the screening test for that would be a low dose CT.
Yeah. Yeah, so that's a new thing the past 4 or 5 years. The evidence has shown clear benefit, and actually the benefit is much higher than for mammography. So I think that the number is that you need to do 1,340 mammograms to save one life. And for low-dose chest CT, it's 1 in every 320. So for every 320 people you scan, one person will survive, which would not have without it.
But that's obviously 320 people that tick the boxes for actually needing a
so the criteria is pretty well set in the guidelines, and we start at the age of 55 or 50, depending on which country you are. you need to have at least 20 pack years of smoking. So on average, a pack a day for 20 years. And you would have stopped smoking less than 15 years ago. And then you get an annual CT scan from the age of 50 to 80 or until more than 15 years after you've stopped smoking. But if you continue smoking, obviously, then you can continue getting the scan until the age 80.
And obviously in a country like South Africa, where we have quite a high number of TB, that does have some influence on the low-dose CT scan. I mean, you can see nodules, but then you use certain cutoffs and just repeat the scan to make sure, or
generally with TB, nodules are often small calcified nodules, and they're often surrounding cavities, and they have a typical distribution that we can be sure that they're post-infective, and certainly there are some TB granulomas that don't calcify, and we would follow them up. So how the screening works is you get an uncontrasted CT, same as the calcium score, and we would look for nodules. We'd have AI software helping us to find every single nodule, measure each nodule, and any nodule more than 6 millimeters would get follow-up. Depending on the size, the follow-up would either be in 6 months or a year, and we would see if it's very simple to see if it grows. If a nodule stays stable over 1 or 2 years, then it's almost certainly not an issue. And if you see a new nodule, then you need further workup. Or if a nodule increases in size, we would recommend you see a pulmonologist or a thoracic surgeon, and they would manage that further, either with a biopsy or a PET scan or bronchoscopy, depending on where the nodule is.
Good. We actually touched now on the mammography for our female clients. That's also something we order. We talked about the big 5 for the men and the big 5 for the women. So breast cancer, obviously, in there, you touched on that it's maybe not our specificity and sensitivity on a mammogram might not be the same as for CT, but it's still something we do.
Yeah, mammograms, even though you need to do 1,300 people, every single woman will benefit from it from the age of 40. So the international recommendations is from the age of 40. And in South Africa, the recommendation is annually, every year from the age of 40. The benefit, getting an annual mammogram reduces mortality by 20 to 30% after the age of 50. And so 20 to 30% of people who have mammograms will survive versus not having it. And it's a bit less between 40 and 50, I think 15 to 20%. And obviously the risk of, it's a low dose exam. The radiation is not the risk. The risk in parentheses is the discomfort part of that. Some people don't like it. You have to put the breast in a X-ray machine. There's some pressure. And then obviously not all biopsies or not all lesions we see is cancer, but we don't have, the mammogram is not extremely specific. So if we see something that might be a cancer, we tend to recommend a biopsy. Our threshold is actually quite low. If there's a risk of more than 10% or 5 to 10% of it being a malignancy, we would recommend biopsy. Lesions that look benign, completely cystic, we would just ignore. Or if it's almost certainly benign, we would maybe follow it up. But if all our biopsies were to be positive, we would miss a lot of cancers. So, and that's probably the biggest drawback, that if you have a mammogram every year for 30 years, there's a good chance that at some stage you might get a biopsy, which will hopefully be negative. But if you do find a cancer, you're going to find it early and, at 1 or 2 centimeters, which means you can get, minor surgery, breast conserving surgery. You might not need chemotherapy, and your risk of having metastases is much lower.
So obviously the mammogram, if the breast tissue is quite dense, it reduces the sensitivity in the test. Do you then combine it with an ultrasound, or do you go to MRI, or what is your preferred type of approach to something like that?
Yeah, we would do ultrasound. So about 70% of our patients would get an ultrasound as well as part of the mammogram.
So that's quite a high number.
Yeah. And there are 4 four different breast densities from A to D, and all density C and D would get a mammogram. And depending on the population and the patient age, the younger patients, the breast, if they're premenopausal, are definitely much denser. And patients under the age of 50 would probably 90% of them would get ultrasounds. And as the patients get older, the breasts get less dense, and it becomes a bit easier to see. And breast MRI we tend to reserve for patients with a high genetic risk. So if you have the BRCA gene mutations, then recommendation is to start breast MRI screening every year, alternating between MRI and mammography from the age of 30. If you don't get prophylactic mastectomies, which I think many of them, if not most of them, get. But yeah, breast MRI screening is rare, although we do have some patients. We use it for problem solving more.
And obviously, I mean, it gets more sensitive if you go for yearly for your test, because you have a record of your testing. So in private, obviously, I don't know with the other centers, but you prefer to go to the same center to get the previous test so that you can compare with. How is there communication between the different sites or in your practice?
In our practice, all 10 sites are connected. So you can go to any one of our branches, and we often get patients from other branches, and they would usually bring from other practices, they would bring a CD with. But you're right, if you have a comparison, it makes it way easier.
Yeah, and I think people listening to the show, we've had some feedback that people that have not been to our InnerSight screening that actually went to your unit and got a mammogram and got picked up early, being treated, and is actually doing quite well. So we are happy that we're getting the message out there that you do the screening, you pick up something, you get it early, because that's actually what you were saying, is catch it early, get it sorted, and you're going to live longer.
It's actually one of those low-hanging fruits where you can see it early and you can do something about it. Yeah.
Okay. I mean, that's pretty much the tests that we as InnerSight would order. I mean, sometimes there would be a chest X-ray. If someone has never had a chest X-ray, I've ordered some chest X-rays just to get a baseline. My question is that necessary? How sensitive is that as a screening test?
It's definitely much less sensitive than CT. And if you have a nodule, but you could still see nodules. If you have a nodule visible on chest X-ray, it would generally be at least a centimeter and a half, where with a CT you could pick up nodules 2 or 3 millimeters. Although we generally only follow up, the recommendation is to follow up a nodule bigger than 6. But if you do annual screening, it would eventually get there and you'd see it. Yeah, so routine chest X-rays without a history, I don't think there's a clear benefit in that. But, it's an extremely low dose exam. There's no risk to it. And I certainly have seen patients that come for routine employment and immigration chest X-rays where we pick up lung cancers. So that happens, every now and then.
The other thing that we have seen come through is, obviously we do PSA screens as a blood test in our InnerSight program. So with that, you fit either digital exam, and then the two modalities that I've heard of but haven't really done myself is then the ultrasound versus MRI. Do you still do them? How sensitive are they?
Yeah, so we do prostate MRI. And if you have a high PSA, you would go see a urologist first, and he would request an MRI. And that's for biopsy planning. He would want to know, first of all, is there something in MRI that looks suspicious? And he would guide his biopsy into that quadrant. If it, in the past, they would just do blind biopsies. They would do 30 or 40 biopsies of the prostate, which you can imagine is quite traumatic. And but nowadays we fuse the MRI with the biopsy images, and he can do a targeted biopsy to make sure he gets the pathology. Because in the past, if you had a high PSA, you might still get a negative biopsy, and then you're not sure if is the PSA a false result because of a urinary tract infection, or is there actually a small cancer that you'd miss. And if you had a negative biopsy and a positive prostate MRI, they would go back until they find something.
And if you focus it, I mean, the prostate is a little bit bigger than a walnut, so you can actually focus that MRI with small slices and
yeah. You have a dedicated prostate coil, and the resolution is can be down to 1 millimeter.
Wow. While we're talking about the resolution of MRI, we've been asked quite a bit about whole body MRI. So that's something that we hear from our American friends. Is that something you do? Is it?
No, not yet. I mean, well, we're not planning in the near future. There's no evidence that it works. And although in the States, I think that they're popping up all over, and lots of outpatient centers, you can walk into a mall and get them. We're waiting for the guidelines to show that there's benefit before we start doing them. You might just over-investigate and do lots of biopsies on benign lesions, or you might, lead time bias might come into play, where you might start, biopsying and finding cancers and treating cancers that would never have caused any symptoms. And we wait for the guidelines, but it might happen in the next 5 years. And even though it might not be on a population-based screening program, it might not be benefit, but it might come to the point that they say, well, if you can afford it, and you can afford the treatment, because that would probably not be covered by medical aids, maybe, but not yet.
Yeah, well, I think that might lead, as you said, to a lot of concern for some patients. So you need to be open-minded when you enter into something like that. Seeing something that might be not something serious and living with that is not everyone can do that. And then the follow-up period and the anxiety that might come with that. And then, as you said, unnecessary testing to doing biopsies and other things might.
Yeah, well, one of the findings that we found in the pancreas is something called an IPMN, which is a low-grade tumor. You can see it with MRI. You know it's a tumor, and but the surgery to remove it is extremely invasive and massive surgery, and you wouldn't do anything until it grows. So this patient would go back every year and wait for this tumor to grow. So that's a lot of anxiety. But on the other side, if you do catch it before it grows, you've saved his life. But the patients have to be aware of the risks, those emotional risks before they do that. But I don't think there's anyone in South Africa yet that does that.
Yeah, and I think that's the one thing we want to do, like you do, stick with the guidelines, do the things that actually will make a difference in someone's life, going to that good 80 that we talk about. You touched on something when you talked about trying to find tumors, and you said AI helps you to find find the tumors, and that's one of the buzzwords these days. It's AI.
Yeah.
Maybe, are you excited about it? How does it help you?
Yeah, no, very. I mean, a lot of excitement. We've started an AI working group at the Radiological Society. We actually have our first meeting tonight, and many of the practices are getting our first AI products, and there's an extreme shortage of radiologists worldwide, and especially in South Africa. Our workload is increasing, and we're hoping to find some tools that can help us work faster and more accurate. And AI has that promise. Maybe, not within the next year or two, but I suspect within 5 years, all the practices will be using them for almost all the exams. And the products that we use at the moment are, mainly to do the mundane tasks, counting nodules and aligning scans and making sure when you dictate you don't make the mistake between left and right. So the large language models are already involved in our dictation software, just helping limit mistakes. And but definitely a lot of excitement. The international conferences are almost 90% now geared towards AI. And then we don't think it's a hype. We do think it's going to be, very helpful in the next 10 to 15 years, and maybe take my job after that. But nobody knows.
AA still needs to put up that line, or the interventional radiologist. But it's limiting mistakes, or just pattern recognition over time will improve with the help of AI. So I think often people are afraid of, especially in medicine now, it's going to take over our work or things. But like you say, you're using it to enhance your work rather than anything else.
Yeah, you can focus more attention on the important parts, because a lot of the work we do is looking for small things and not necessarily interpreting them. And you'd rather have a computer tell you, these are the 5 things I found, and what do you think they are? And a CT chest and abdomen currently has over 700 or 800 slices. So that means you have to look at every pixel on 700 or 800 slices, and you will miss things, and you might have an off day, or might be tired, and the AI doesn't have that. Every day is his on day, and they would probably initially work as a co-pilot. You would do the reporting, and you would just flag things that you've missed. And then, which is why the large language models are a game changer, because they now understand our reports, and they would literally, when we do a report, if you say there's in the body of the report, you say there's a mass in the right kidney, and in the impression you say there's a mass in the left kidney, it would flag and say, well, you made this mistake. Do you want to go back and change it?
Amazing. That's fascinating. It'll be a while before they put together our data program, because we take everything from blood tests to the skin to radiology. So it'll be interesting when that happens. But amazing, fascinating. Our radiology. We use a lot of radiology, and as doctors, we use a lot of radiology.
Yeah, to make decisions, we need information, and information is we use biomarkers, blood tests, and things like that. And the radiology, we need imaging to make decisions. And without the information we gather from a CAC scan or CT angio, we can't give good advice to the clients or the patients. So, we need it. It's an absolute. We can't work without it in our practice.
Yeah, I think, and the big lesson for me again was it's actually a lot less invasive and dangerous as what the world makes it out to be. It's not that dangerous for the amount of information we're getting, and when we ask for it. So as you say, you wouldn't just scan everyone. There's no need, but for the right person at the right time for the right reason, please go if we or someone says that you should. Hofmeyr, we'll put in the show notes links, SCP Radiology's website, where to find you. Normally people can't just pitch up to do things except for a mammogram.
Yeah, you would even mammograms. We pretty fully booked for a week or a week or two in advance. So you would pitch up for emergencies, usually via the ER. But for anything else, you would generally book. I think you can book on the website at some hospitals, and our website has contact details for all the practices.
And the mammogram you can do without a referral?
Yeah. Mammogram, the medical aids reimburse mammograms every second year, even though we recommend every year. But they, as far as I'm aware, most, if not all of them, do pay for the mammogram, which includes the ultrasound if that's necessary as well.
And for all our tests, we would send the request with you, and you'll book, and we'll do the rest. But just now, our listeners will then understand what will happen in the process. And thank you so much for coming in today. It's like I've learned quite a lot, and I hope our listeners will learn quite a lot and enjoy this episode.
Yeah, thanks for your time and helping us out.
Thanks. Yeah, it's a new experience, but interesting. Thanks.
Awesome. Disclaimer. This podcast is not intended as a substitute for the advice of your healthcare provider. No doctor-patient relationship has been formed through this podcast. The content here is for information purposes only.